This is chapter 18. We will be dividing this chapter up and discussing lupus at this time, and in a video that I will do for week after next, we will be discussing osteoarthritis. So lupus is a chronic, progressive, inflammatory connective tissue disease that can cause major body organs and systems to fail. These patients can have remissions and exacerbations. All exacerbations are flare-ups. The onset can be acute or it can be insidious, which means slow. The condition is potentially fatal, but most patients with SLE can live many years after diagnosis and lead productive lives, but they do have to have a treatment for the lupus to have prolonged survival. Lupus is thought to be an autoimmune process. Anti-nuclear antibodies, or ANAs, primarily affect the DNA in the body, the RNA, and other components within the cell nuclei. As a result of this interruption, immune complexes form in the serum and organ tissues, and this causes inflammation, damage, and destruction. These complexes invade organs directly or cause vasculitis, which is vessel inflammation, and it deprives the organs of arterial blood and oxygen. This, for these particular patients, can cause a lot of pain. It can cause potential problems in most of the individual's body systems. The autoimmune complexes, particularly like the glomeruli of the kidneys, so therefore most of these patients have some degree of kidney involvement. It just depends on, how long the disease has been there as to what degree of kidney involvement they'll have. Lupus nephritis, which is the kidney involvement, is the leading cause of death from SLE, and the other causes that we see are death from cardiac and central nervous system involvement. The onset of this disease occurs most often during the childbearing years, approximately 20 to 40 years. It has been seen in some young children and older adults. Does have a trend to develop in some twins and some families, some hereditary properties. Like rheumatoid arthritis, lupus is probably caused by a complex combination of genetic and environmental factors, and some patients that are on medications like procainamide or hydralazine can have some signs and symptoms of a lupus-like syndrome. So some of the clinical signs and symptoms that we see, some skin involvement. On the next slide, you'll see the picture of the butterfly rash. It begins on the bridge of the nose and forms out into the cheeks. These patients can have, and this is a dry, scaly, raised rash on the face. It's initially non-scarring, but it can increase in the flares and the remissions that the patients have, and it does disappear a lot of times when the disease is in remission. In addition to other skin changes, patients can have polyarthritis, and this does occur in most patients. These are early joint changes that are seen with those in rheumatoid arthritis, but severe deformities in lupus are not common even in late disease like they are in rheumatoid arthritis. Small joints, like in your fingers and hands and in the knees, are most commonly inflamed. These patients can have osteonecrosis. It's where you have a bone necrosis from a lack of oxygen, and this is seen in patients who have been treated with steroids, things like prednisone, for at least 5 years. You want to observe for muscle atrophy, which can result from disuse of the muscles because these patients are hurting so bad, and also from chronic steroid therapy. They can have myalgia, muscle pain can occur, and upon your inspection, you want to be inspecting and palpating the major muscles, like the ones in the legs and the arms, and especially those in the extremities. Remember that SLE or lupus is an extreme inflammatory condition. Fever and fatigue are common findings. Fever is the classic sign of a flare or exacerbation, and various degrees of generalized weakness and fatigue, anorexia, and weight loss may occur. These may not be the only signs and symptoms of the disease, but they can provide your physician a basis from which to work from. Any and all body systems can be affected by SLE, and because the lupus nephritis is the leading cause of death, you want to carefully, as a nurse, assign for symptoms of renal involvement, changes in urine output, proteinuria, hematuria, and fluid retention. Pleural effusions are found in almost half of all cases. This is not a life-threatening complication, but these patients can have restrictive or obstructive changes, and that you may not see a lot of signs and symptoms. But as the lupus continues to get worse, then the patients can have shortness of breath, arterial blood gas, ABG abnormalities. So we need to perform a complete respiratory assessment to determine any abnormalities in their respiratory pattern or their breath sounds. Pericarditis is the most common form of cardiovascular signs and symptoms in this patient. It can cause tachycardia, chest pain, and myocardial ischemia, which is a dying of your cardiac tissue. They need to have vital signs monitored every 4 hours while the patient is in the hospital. Report chest pain immediately. Anemia, leukopenia, which is a decrease in your white blood cells, and thrombocytopenia, a decrease in your platelets, are also common in these specific type of patients. Raynaud's phenomena occurs in a small portion. You will find that these patients have really, really cold hands and feet. The patient reports a red, white, and a blue color changes and severe pain in their digits on their fingers. The changes are caused by an arterial vasospasms. So when these changes occur, their hands are or their hands or feet are exposed to cold, or when they are extremely stressed, then they'll have this significant pain. Neurological manifestations can vary. Things like paresis, seizures, migraine headaches, cranial nerve palsies, or peripheral neuropathies are common, and we need to perform a good neurological assessment on them. There is something called serositis, which is a peritoneal involvement from lupus. So if these patients are complaining of abdominal pain, then they can have things like pancreatitis, colonic ulcers, which can cause the abdominal pain. Jaundice is not very rare. A lot of people have lymph node enlargements, and some can have splenomegaly or an enlarged spleen. Need to palpate all of the lymph nodes and document any abnormal findings. And vasculitis, which again is just an inflammatory of the blood vessels, can lead to organ failure. So again, this is the butterfly rash that's characteristic. It starts at the bridge of the nose and spreads out through the cheek area. So for these particular patients, this diagnosis can be very detrimental and devastating to them. The rashes can be disfiguring. They can be embarrassing. If there is chronic steroid use involved, there's side effects such as acne, fat pads, and weight gain can intensify the problems they're having and can cause an alteration in body image. These patients have a lot of chronic fatigue, generalized weakness. They may prevent your person from being as active as they want to be. They tend to withdraw from their family and friends and social gatherings because of fear, anxiety. And, lupus is not fatal like it was thought to be like in the early 60s and 70s. These patients can live long and productive lives, but they do need a lot of support. Need to assess the family and feelings, patients' feelings about the illness, how they're coping with it, and determine their usual coping mechanisms. Laboratory findings that we can do: a skin biopsy helps to confirm our diagnosis. Of course, a CBC can show pancytopenia. Pancytopenia is where you have multiple blood cell counts that are low: white blood cells, red blood cells, platelets. Immunologic based laboratories, those are things like an anti-DNA, and I will not be testing you on all of these specific tests for this, but you need to know about your ESR, which is your SED rate. That shows inflammation in the body's system, and that is specifically an important test for this. And then they can also do what we call a rheumatoid factor that again shows inflammation in the body. So some of the drug therapy that can be used with this particular disease. Topical cortisone drugs are really good for the skin rashes. They help reduce inflammation and prevent fading of the skin lesions. Tylenol or nonsteroidals can be used to treat joint and muscle pain and inflammation. Plaquenil is a medication that is used for some patients. It's actually an anti-malarial agent. It decreases the absorption of ultraviolet light by the skin, and therefore it helps to decrease the risk for skin lesions. With patients on Plaquenil, they need to have frequent eye examinations before starting the drug and every 6 months thereafter. Also, chronic steroid treatment, immunosuppressant drug therapy. Patients who have a lot of renal involvement, you do not want to give you can give immunosuppressants in combination with the steroid. You just have to watch their lab values. The first drug that was ever approved for SLE is Belinsta. And again, I'm not going to make you remember these specific drugs. You do need to know about Plaquenil. We need to treat these patients to protect their skin, to help prevent an exacerbation of the disease, to clean their skin with mild soap, things like ivory, and to avoid harsh perfumes. The skin should be rinsed and dried and should be lotioned really well. Another sign and symptom of SLE is hair loss, or alopecia is extremely common, so patients want to give special attention to their hair. Use mild protein shampoos in avoidance of things like permanents or highlighters until the hair regrows during the remission period. Alright, we're going to move on to scleroderma. Scleroderma is a chronic inflammatory autoimmune connective disease also. Scleroderma means hardening of the skin, which is one of the signs and symptoms of this particular problem. Some people only have skin involvement. Others have other problems like skin and other body systems involvement. The early inflammatory process is similar to that of lupus. Patients may be first diagnosed with lupus, but as the disease progresses and as they do more testing, there's a specific antibody testing that supports the diagnosis of scleroderma. The inflamed tissues in patients with scleroderma becomes fibrotic and then sclerotic or hard. Renal involvement, again, is also the leading cause of death. Respiratory involvement and hypertension are also common. And patients with scleroderma do not respond well to steroids and immunosuppressants, so the mortality rate is a lot harder with these particular patients. Diffuse cutaneous is just a skin thickening on the trunk face, and proximal and distal end of the extremities, which is basically most of the body. Limited cutaneous is a thickened area limited to the face, neck, and the distal extremities. Patients with the limited form also have the crest syndrome. This picture shows what the scleroderma looks like, and you see how inflamed the joints, the tissues are in the fingers. So, as we talk about crest syndrome, remember this is associated with patients that have limited form of scleroderma. The C stands for calcinosis, which is calcium deposits in the body. You have the Raynaud's phenomenon. That is the first symptom occurs, and again, that is these patients' hands and fingers will actually look blue, and they will be extremely cold to the touch, and they tend to be like this during all of their exacerbations, and they will have extreme pain in those hands and fingers. Esophageal dysmotility, sclerodactyly, which is scleroderma of the digits, which is the slide before this showed. And then telangiectasia, which are spider-like hemangiomas on the fingers and arms. The first symptom that usually occurs in these patients is the diffuse form, which is in the hand and forearm swelling or edema. And then they can also have carpal tunnel syndrome associated with that. GERD is commonly present in these particular patients. So scleroderma signs and symptoms are the arthralgia, the pains, the aches, renal and cardiac system involvement, problems with the GI tract like GERD and ulcers. They can have the esophagus loses its motility. They have a lot of problems swallowing. Again, we've just talked about that they have Raynaud's phenomenon, cardiovascular problems, and then they also have a lot of lung problems. The lung involvement can go undetected until really late in the disease process, and they can have fibrosis of the alveoli and the interstitial tissues in the lung. Patients with scleroderma can have pulmonary artery hypertension, and then but the renal involvement is really the most important aspect, because this is really what causes the malignant hypertension and eventually causes death. You can have signs of organ failure and need to be looking at changes in the urine output and the increased blood pressure. So how do we treat the scleroderma? We need to manage each individual organ separately. We need to force the disease into remission, which helps to slow the disease progression. So the primary drug primarily used for this purpose a lot of times is often unsuccessful. Steroids, immunosuppressants are used in combination therapy. We want to identify early organ involvement and treat it before it becomes severe and irreversible. Skin protective measures, again, patients need to stay out of the sun, use sunscreen and other things to protect themselves. The new drug that is being used is called Tracleer. It's the first of a brand spanking new class of drugs. It helps to improve a patient's breathing during exercise, but it does have a potential for liver injury, so they must be monitored closely for that. TKIs are also a new drug class being used. Again, I'm not going to make you remember all of these medications. The TKIs do help to decrease inflammation and slow the progression of the disease. You just need to remember that particular part. Teaching the patient to use mild soap and lotions, gentle cleaning techniques, inspecting the skin for further changes, open lesions, and then we'll treat them as necessary. Patients with lupus experience chronic joint pain, severe acute pain during episodes of the Raynaud's. If the patient has any type of esophageal involvement, they may need speech or language therapy to conduct swallowing studies, may need small frequent meals rather than the traditional 3 meals, may have to minimize the intake of food and liquids, decrease spicy foods, caffeine, alcohol. Teach the patients to keep the head of the bed elevated for 1 to 2 hours after meals, and then can use histamine antagonist and an acid, things like Benadryl, Tagamet, things that will help decrease and neutralize the gastric acid. Gout is also called gouty arthritis. Gout deposits uric crystals in the joints and other body tissues. It causes inflammation. It's most common in older adults, affecting about 6.1 million people. The cause has not been firmly established. There are 2 major types of gout, primary and secondary. Primary is the most common type, can result from one of several errors of purine metabolism. The end product of purine metabolism is uric acid, which is excreted by the kidneys. In primary gout, the uric acid exceeds what the kidneys are capable of excreting out, so then you have a buildup of uric acid. Sodium is deposited in the synovial fluid and other tissues. This leads to inflammation. A number of patients have a family history of gout. Again, it affects the middle-aged and older men more, and then postmenopausal women. The peak onset for men is between 40 to 60 years of age. Secondary gout involves hyperuricemia, which is excessive uric acid in the blood. It affects people of all ages, causes renal insufficiency, diuretic therapy, a lot of crash diets can cause excessive uric acid in the blood, and then certain chemotherapies can cause extreme uric acid in the blood and cause a lot of other waste problems. Diseases such as multiple myeloma and certain cancers can result in increased production of uric acid because they have a larger, what we call cell kill, so you have a lot of additional waste products in the blood. So treatment involves managing what's causing the secondary gout. It's generally seen a lot of times in patients with cardiovascular health problems, obese people, postmenopausal women. The patient is usually unaware of a lot of the symptoms unless they have had blood work that states that they have high uric acid levels. The first attack begins what we call the acute stage, and this patient starts experiencing excruciating pain and inflammation in one or more of the joints. In ESR, erythrocyte sedimentation rate, which I discussed a few minutes ago, is usually increased as a result of the inflammatory process. After repeated episodes of gout, you have large amounts of crystals, uric crystals developing under the skin within the major organs. And from then on, I'm going to go ahead to our next picture. You have the tophi, and this is called chronic tophaceous gout. You will see that the patients have a lot of joint involvement, and then they have these little lesions on top of their fingers. Tophi are rare, but they're just caused from the deposits of sodium urate crystals. They can appear on the outer ear, arms, fingers, near the joint. They're hard when you palpate them, and they're irregular in shape. When it's irritated, they can break open, and you can have a yellow gritty substance, and then of course you can get infections. Remember that joint inflammation is the most common finding of acute gout, and it's usually so painful that the patient seeks medical care pretty quickly. So interventions for gouts, of course, is drug therapy. There are a couple of different medications that gout is used to treat. That treat gout. You can use nonsteroidals medication such as Indocin. There is a medication called Xyloprim that's used to treat gout. Colchicine is also used in acute cases, and the patients generally take these medications until the inflammation goes away, and that's usually about 4 to 7 days. We want to limit their proteins, avoid the trigger foods for them, which may be things like caffeine, alcohol, which has purines in it, can cause triggers. Aspirin should be avoided. Diuretics, they can precipitate an attack. These patients need to drink plenty of fluids to prevent the formation of the urine stones, and that also helps to dilute the urine and prevent sediment formation. Uric acid is more soluble in urine with a high pH, and it's less likely to form urinary stones in that particular environment. A low purine diet these patients need to be on, and purines are things like organ meats, shellfish, oily fish, things like sardines. I've already said limiting the protein foods, especially the red and meats. And of course, like I've already said, excessive alcohol intake and starvation diets can cause an attack as well. These are some of the other connective tissue diseases. I'm not going to go over them. If you want to look over them, you can feel free to, but I'm not going to require you to know them. Lyme disease is caused by Borrelia burgdorferi, which results from the bite of an affected deer tick. It is an infectious disease, and most cases of the diseases are in the United States and New England. In stage 1, the patient can appear with flu-like symptoms. They may have round or oval or flat or slightly raised rash, pain and stiffness in the muscles and joints. There sometimes can be what they call a bullseye lesion. Symptoms generally begin within 3 to 30 days of the tick bite, but most are present in about 7 to 14 days. Antibiotic therapy like doxycycline or amoxicillin is prescribed during what we call the uncomplicated stage, and most of this clears up without any problems. Without treatment, the symptoms may disappear in about 4 to 5 weeks. If it is not treated or treatment is not successful, the patient may progress to stage 2. It occurs about 2 to 12 weeks after the tick bite. Patient can develop carditis. They can have dysrhythmias, shortness of breath, dizziness, palpitations, central nervous system disorders, Bell's palsy, meningitis, facial paralysis. So this disease can be very severe. At this point, patients will require IV antibiotics, which must be given for at least 30 days. And sometimes the first and only symptom could be arthritis. This is a picture of the round bullseye rash from the Lyme disease, and the second picture is showing a little bit broader flat rash. We're just going to basically go over psoriatic arthritis. For patients who have psoriasis, which is a skin condition characterized by scaly, itchy rash of the elbows, knees, and scalp. The joints are really stiff, especially in the morning, and the treatment focuses basically on just managing the pain for these particular patients. Psoriatic arthritis occurs in people between 30 to 50 years of age, men and women. Nail symptoms are common in patients who have psoriatic arthritis, and some of the causes can be genetic and environmental. That's all you need to know about that. Fibromyalgia syndrome is a chronic pain syndrome. It's a chronic it's not an inflammatory disease, it's chronic pain. But arthritis and other things like pain and stiffness and tenderness can be diagnosed with fibromyalgia. They have specific sites of tenderness in the back of the neck, the upper chest, trunk, low back, and extremities. They have tender points, which are also known as trigger points, and they can generally tell you where they're hurting. The pain is specifically described as burning and gnawing, and these patients, hurt a lot. They have a lot of fatigue, and there's not a lot that is out there to treat fibromyalgia. Currently, a lot of the symptoms are based on treating the symptoms. Patients can get very frustrated because when the disease was first diagnosed and first noted, the patients were not getting properly diagnosed, and they were in a lot of constant pain and discomfort. You will see fibromyalgia patients diagnosed with chronic fatigue syndrome, and then some of these patients can get really depressed and anxious. Most patients are women between 30 to 50 years of age. Possible factors that can contribute are Lyme disease, trauma, some flu-like illnesses, and then it can also be aggravated by sleep deprivations. These patients need to be taught to limit their caffeine or alcohol and any type of unnecessary substances that can interfere with deep sleep, and they need to establish a regular sleep pattern. And this is just a really pretty picture of the pathophysiology of fibromyalgia. Okay. Chronic fatigue syndrome is just a severe fatigue for 6 months or longer. It usually follows a case of flu-like symptoms. There are 4 or more criteria that must be met for a diagnosis of chronic fatigue syndrome. There's a list on page 322, but they qualify as a sore throat, impairment in short-term memory, tender lymph nodes, muscle pain, multiple joint pains, headaches, and not being able to get enough sleep. We want to supportive treatment, treat the signs and symptoms. This is the end of this lecture. Thank you.